And we are now live.
Got it. Good morning, everyone. This is Senate Health and Welfare Committee meeting. It is January 20th. And this morning we are looking at Medicaid a little bit with our experts in that area, Nolan Langwell and Ashley Berliner. I'll let you each introduce yourself and then we'll hear your testimony, your information. It's not really, it is testimony, but it's really critical important to us.
Great. For the record, Noel Langwell, Joint Fiscal Office.
Ashley Berliner, Director of Medicaid Policy, Agency of Human Services.
So I invited Ashley to do this with me for the third time for multiple reasons. One is she's the expert on a lot of what we're going to be talking about, but also I think it's really good for folks to start seeing who the brilliant people are behind the veil that are doing a lot of the work of things that make Vermont tick. I'm going to share my screen. And I'll also say that, I think after today, I think you'll be done with me for a little while in terms of bombarding you with information. And I'm sure you'll be thankful for that.
But we'll have you back to clarify everything we don't.
Yeah.
Know, right? Good.
The other thing I would say is I have a bunch of slides from the beginning. I'm going to go through them really, really quickly because a lot of it's repeat and it's also me telling the story. But also what's also happened is the global commitment stuff is towards the end. And that's the stuff I really want you to hear about.
Okay.
So I want to kind of tell you a quick story to get you there, but make sure you have enough time, that there's enough time for Ashley to walk you through global commitment and for there to be questions. So if you have questions, I would ask that we keep them quick.
All right, we'll hold, and we can hold, unless it's a clarification of what's there. Why don't we hold the questions and, write down here.
So I really want to get the global commitment.
Good, okay.
I'm going to get there quickly. So if I go and then write your question down, we can revisit it if there's time at the end.
Sure.
So again, this is meant to be a high level overview of global commitment. So I start by just showing you again, here's our chart that you've seen before. We're going to be talking about that 24% of Vermonters, the Medicaid use. Again, I've told you that the reason I threw this in here is I was telling you the story, if you remember, of how, it used to be in 2008, 30% of Vermonters had some form of government coverage. And now in 2021, 45%. So we've seen a shift. You've seen the Medicaid numbers go from 16% of Vermonters to 24% of Vermonters between 2008 and 2021. This one we can ask, well, don't ask too much questions about this, but high level, the Medicare and Medicaid, there's a difference between them, and they're easily confused because their names are both so close together and they cover a lot of the same stuff. So I've been doing this for this third time I've done it, and every time someone has sent me some kind of little trick, oh, this is how we remember it. So my favorite though, I think it was Representative Goldman. She said, remember, Medicare ends in E for elderly.
Mm-hmm.
But then someone else said, so I like that. But
mostly
maybe,
no,
yeah.
elderly.
50,
Some does not.
at 55, I think you come on. You're not quite elderly, but I'm not 55 yet, so I'm only 29, remember? And so the difference is Medicaid is state and federal program, Medicare is federal only. So we do not have any influence, say, or whatever over Medicare. We only control Medicaid at the state level through the state budget. Medicaid is for low income, it's for children, adults, 65 older, blind, or disabled. Medicare is all incomes, it's just 65 or older. Any age with, or any age with end stage renal disease, or if you have certain disabilities and you're under 65, you can be on it. But most importantly, the thing to remember, I think, is that Medicaid is a thing that we have some influence in the budget. Medicare is federal, and that's out of our hands.
Thank you.
So real background, Medicaid started in 1965. It's a public health program for low-income individuals and families and individuals with disabilities. Again, it's financed through a federal-state partnership, but administered by the states. And I'll get into a little bit more details in a few slides here. And each state designs and operates its own program with broad federal guidelines. And there's this joke is, you heard me still this joke. And I think that after you hear the global commitment talk, after Ashley, this little line will make more sense and be funnier. But if you've seen one Medicaid program, well, then you've seen one Medicaid program. I think that's hilarious. You don't yet, but you will. If that doesn't work, I'll tell you my
I
actual.
totally think it's hilarious.
See? Because this is our 7th time here in this presentation. Nationwide, there's 90 million folks who are on Medicaid in Vermont. The number is 208,000 Vermonters receive some form of Medicaid assistance. Again, I think I talked about this last time. There's the have some form of assistance versus those who are on Medicaid. 1/3 of folks have assistance, but a quarter are on as a primary. So of that 208, 163,000 have that as a primary. And the rest are some form of like premium assistance or prescription drugs, etc. So eligibility, when I think about eligibility, I think about, or when I think about coverage, I think is who is covered and what is covered. So for the WHO, in order to qualify, you have to be a Vermont resident, you have to be a U.S. citizen, permanent resident, or non-citizen with lawful presence. Your financial situation will be characterized as low income or very low income, and be one of the following: pregnant, responsible for a child 18 years old or younger, blind, have a disability or a family caretaker of someone with a disability, or 65 years of age or older. And when we talk about benefits, I don't think I put that chart in here. I have another chart that I did not put in this particular presentation, but it just shows like what we have mandatory benefits that we have to cover, and then there's optional, and that comes from a menu of things that we don't have to cover, but we do. And in the previous presentation, I had that list. The one I gave you earlier, on the one side, there was those that we have to cover, and then there's those that we don't have to cover. I think we might have had this conversation.
I think, yeah, we have it on our.
That's
side,
right.
Yeah.
Okay. So spending, again, another slide you've seen before, but again, like to tell the story and kind of repetition is good. So that 24% of Vermonters is 27% of our total spending. We spend about $6.3 billion on healthcare. This is a 2020 number. We don't have the 22 number yet, but 27% of that was for Medicaid spending. State budget, again, I think I've shared this slide with you in the bigger presentation, but Medicaid is a huge part of our budget after pre-K. Pre-K is the biggest, but Medicaid is close second. But then when you look at the state from our federal, so the blue is state dollars, the orange is federal dollars. And so for federal, we get the most amount of our federal dollars from for Medicaid.
It's not pre-K, it's K-12.
I didn't make this slide.
It says pre-K.
It says, oh, it says PK through 12.
PK-12.
Yeah, sorry. Thank you for the clarification. Overall Medicaid expenditure is 1.9 billion. It's funded through a combination of state and federal dollars. Overall, across the board, we get federal match for different pieces. I'll get into the mechanics of that, but roughly 70% of our Medicaid program are federal dollars. That's a huge amount. A lot of that is through matching dollars and with this thing called FMAP. You're going to hear a lot about FMAP when you hear from the adjustment and the budget. And basically, it stands for Federal Medical Assistance Percentage. And there's multiple FMAPs for different programs and for different populations. But ultimately, it's the percentage that the federal government pays for a particular program or for a particular population. We do not determine FMAP. FMAP is determined by the federal government on an annual basis. It's calculated on a 3-year average of state per capita personal income compared to the national average. And then there's limitations. No state can receive less than 50% or more than 83%. So for instance, states with high per capita income are all around 50%. They can't go below 50%. The federal government will always match at least 50 or more. You have California, your Colorado, your Connecticut. And then you have your states that have not as great of a state per capita income. Mississippi, you can see they have a very high FMAP, 77%. We have multiple FMAP, but the majority of our FMAP, our basic FMAP, is around 56.75%. That's the federal share. Additionally, states are also receiving a 6.2% bump in FMAP as part of the federal family's first coronavirus Response Act. That is the recent, and Ashley can talk more to this, but the recent federal legislation began the unwinding of that, and we will start to see that FMAP decrease and eventually disappear. But tied to that is this thing called maintenance of effort or eligibility, MOE. And basically what this says is that during this time that we're getting this additional FMAP, we cannot change eligibility standards or kick people off or do what's known as redetermination. So redeterminations, and you're going to hear about this when you hear about budget adjustment. Basically, redetermination is a process by which, maybe we talked about it here, I can't remember, but if you think about coming in and then coming out of the program. So you have people, eligibility is determined for people to be in the program, and then they redetermine to see if they're still eligible for the program. So normally we have this thing called churn, where people come into the program, and then each year we determine some stay, some leave, and our Medicaid populations continue to increase over time. That's because the amount of people coming in has been greater than the amount of people coming off. Well, because of this particular benefit right now, we also can't do redeterminations, which means that people are coming onto the program, but they're not coming off. So we're seeing a spike in enrollment, and you'll see that and in budget adjustment. But the flip side is we're also getting federal match dollars to help pay for that as well. So, and I think when you hear the budget conversation, we won't get into the mechanics of the federal bill that's going to unwind that, but that'll be a part of the conversation when you hear about the budget, when eventually the administration comes in and talks to you about what's in their budget and the numbers. But that's a big piece that's also driving our budget adjustment. So when you hear about redetermination or churn or why our Medicaid populations are so high right now, that's a big piece of it. We also have enhanced FMAPs, and these are for our expansion populations. So we have multiple FMAPs. We have our regular FMAP, which is the majority of our program. We have Children's Health Insurance Program, which is a subset of our, it's a federal program, but we administer as part of our Dr. Dinosaur program, which is our Medicaid children's program. But we get a special FMAP for that particular group, and that's 4,700 kids. And another FMAP we have is for children, what's known as childless adults. And don't let the name fool you, or childless new adult. They're not new, but the title is kind of deceiving. But it's 47,000 childless adults for which we get this 90-10 match. So, and I'll walk through these again, but basically, in short, FMAP is, essentially for every dollar we spend, 56.52 cents are federal and 43 cents are state. Or roughly every dollar we spend on Medicaid, state dollar, we're getting $2.30 worth of program. So we're going to put $1 in, the federal matching is $1.30, and we're getting $2.30 worth of program. The flip side is in the years where we've had more economic difficulties, and your predecessors had to look at cutting services or finding money. When you cut a state dollar in the Medicaid program, you lose $2.30 in services. So it's a double-edged sword. Again, we get this. We have this roughly 70-30 for the Children's Health Insurance Program, and then this 90-10. It was part of the Affordable Care Act, and when it first came out, we were at 80-20, and then you have states that were, I think they called them the do-gooder states, that were already doing expansions. They were getting 80-20 in this population. Then the states that were not doing anything, like Mississippi, were getting 100% federal pay match on these folks. And then over a period of 5 or 6 years, everybody worked down to 90-10. We're at 90-10 for this particular population now, for perpetuity. So, but it's been helpful because there's a lot of people in this population. And this does not include the 6.2. This is the base, and then we would add the 6.2. The 6.2 is additive to the regular FMAP, so we would add 6.2 to 56.52. We don't get the 6.2 on the childless adults. And then for the children, it's kind of embedded in the formula. So you wouldn't add 6.2, it's more like embedded into the calculation. So it's a little bit different. But not to get too much in the weeds, FMAP is an important part of how we fund our Medicaid program. This slide I like because it shows you the cycle. So there is a correlation between economic well-being of the state and FMAP because it's tied to it's a more complicated formula, but ultimately it is the 3-year average of per capita relative to the other states. So when our FMAP goes up, we're like, great, we're getting all this extra federal dollars. You know, if our FMAP goes up by, 6%, that's $22 million a quarter, it's $80 million a year. It usually goes up by 0.01 or 0.02, but that can translate to $3 or $4 million. The flip side is when our FMAP goes down, it might cost, $3 or $4, $10 million extra to maintain the same level of service for the same population. But the flip side is what I always think about is if our FMAP is going down, which is a bad thing for our state budget, it's one of many signs that means that our per capita income has increased a little bit. So there's that sort of thing to think about. It's a bellwether, but not necessarily a complete sign. So you can see that there's like a trend. So the gray years are where our FMAP decreased, and the white is where it increased. So you can see it's kind of done this through the years. And I tried to look at like the relationship between those and recessions, and there is a correlation. Not a very strong correlation, but there is a correlation. All right, we blew through that quickly, but now I'm going to pass the mic over to Ashley Berliner to talk to you about global commitment.
Oh, good. That was terrific. And we already have a lot of this on your other slides, but it's so good to hear it again.
Yeah, and global commitment, you probably will have a lot of questions about this.
Yeah.
So that's why I wanted to make sure there was time.
I had to.
Thank you. Thanks, Nolan. So the global commitment to health is what Vermont calls its 1115 demonstration waiver, which is an agreement.
Ashley,
Yes.
is there a way that you could improve your sound? It's a little bit garbled.
Is this better?
It is a little bit. It is better.
Okay. Sorry about that. Keep my hair out of the headphone. Let me know if you're losing me again. So the global commitment to health is what Vermont has called its 1115 demonstration waiver, which is an agreement between a state and CMS. The Centers
Ashley?
Yes.
The sound deteriorates when you start to talk.
Okay, let me try something else.
All right.
I'm sorry, I thought the
This is the
headphone would be
benefit
better.
of Zoom.
I think she's also too far.
1 second, let me disconnect.
No,
She's using her
Is
Bluetooth.
this better?
Yeah, I think the closer you are to your microphone, the better it will be.
Okay.
Try again.
Is this okay?
Still not.
Worse. Okay. How about this?
I guess if you talk really loudly, it'll work.
Yeah, talk loudly and
slow.
slowly, and then we'll be okay.
Okay. Can you hear me?
Okay. We can, yeah. Is that good? Go. All right. And if you start going too fast or it gets worse, we'll stop again, but please go ahead.
Okay. Let me try one more thing. I'll try corded headphones here.
Uh-oh.
Center for Medicare and Medicaid Services.
Can you hear me?
Better.
Yes.
We can hear you.
Is this better?
Oh, yeah. Oh, yes.
Woo-hoo!
All right.
Excellent.
Okay. So take 5. Global commitment to health. That is what Vermont has called its 1115 demonstration waiver, which is an agreement between a state and the Centers for Medicare and Medicaid Services, CMS, to administer parts of a Medicaid program. So back to Nolan's hilarious joke about if you've seen one state Medicaid program, you've seen one state Medicaid program. I would say, I think it's 47 or 48, it fluctuates, have an 1115 demonstration waiver. They're all called different things. In Vermont, it's global commitment. Most states have a very tiny portion of their Medicaid program under their 1115 waiver. In Vermont, our entire Medicaid program, every single bit of it, with the exception of dish payments, funny enough, is under our 1115 waiver. And so what that means is A, Vermont's extremely unique, and B, we are able to waive certain provisions of federal law related to Medicaid and how it's administered to give Vermont additional flexibility in carrying out and operationalizing the Medicaid program. Without the global commitment waiver, we would be limited to what CMS approves in a state plan. And we would have to be strictly in compliance with Medicaid regulations, either fee for service or managed care. So one of the key aspects of any 1115 waiver in any state is that it must be budget neutral for the federal government. So you can't spend more with a waiver than you would have spent without a waiver. In Vermont, an 1115 waiver or global commitment waiver has existed since 2005. Since that time, the Choices for Care waiver has been incorporated into the global commitment waiver. So we used to have 2 1115s, now we have 1. And it really does 2 big things for the states. It gives us additional money, federal dollars that we wouldn't otherwise have. And it gives us additional flexibility to administer the Medicaid program in a way we otherwise couldn't. So on the money side, we get federal funds, federal matching funds to pay for all sorts of things. And here's a not exhaustive list, but the marketplace subsidy, Vermont premium assistance for individuals buying qualified health plans on the exchange. The Community Rehabilitation and Treatment Program, which is a supplemental insurance product for individuals with severe mental illness, providing that above Medicaid limits. V-Farm pharmacy assistance for elderly Vermonters who are on Medicare, which is a full prescription wraparound service. It provides the same prescription coverage as individuals on Medicaid for those at higher income on Medicare. Choices for Care Moderate Needs, Global Commitment Investment, Institution for Mental Disease Payments in Vermont. That is we have 3 specific psychiatric institutions, the Brattleboro Retreat, Vermont Psychiatric Care Hospital, and Lund Home. And then we have several other substance use disorder residential treatments that qualify as institutions of mental disease that we wouldn't be able to pay for without our waiver. And in Vermont, there's in federal law, there's a really obscure regulation from the 60s that prohibits Medicaid for paying for any institution over 16 beds that focuses on the treatment of mental illness or substance use disorder. And so I'm sure some of you have been here for a long time, have heard about the IMD phase down and IMD exclusion. And so our waiver is what allows us to pay for those facilities. We also have cost-effective alternative authority to be able to pay for services that aren't typically Medicaid covered, but are cost-effective. So an example I always use is something like acupuncture, which is potentially cost-effective over something like back surgery. When we can think about more innovative, lower-cost interventions for people where Medicaid wouldn't traditionally cover it, we have the flexibility to if it's been proven effective. We also pay for palliative care services for children above income who are at end of life, substance use disorder coverage above Medicaid limits, and permanent supportive housing services. Those last 2 with the asterisks are newly authorized under the amendment that was approved in July of 2022. And so we're in the middle of plan design and thinking through how to turn those benefits on and operationalize them. They're not currently available to any Vermonters, but we're working really diligently to stand those up and make sure that they're available by 2025. So I'll stop there. I know that's a lot on just the money. Do you have any questions before I move on to the flexibility, or do you want to hold questions to the end?
That's up to you, Ashley, whichever you prefer.
I'm happy to hear questions about the financial participation from the feds if you have any on those top bullets.
Okay, we're good.
Okay. Oh, wait, sorry. Go back, Dolly. Go back. On the flexibility side, we are able to administer Medicaid using a really unique model, which is in Vermont, what we call a public managed care model. We're the only state in the country that does this. Most states contract with an Aetna or a Kaiser to administer their Medicaid program. Some states have 30 different managed care products and plans. In Vermont, instead of contracting with a for-profit managed care or nonprofit managed care organization, we actually contract as AHS. We contract with the Department of Vermont Health Access to be our public managed care plan. That allows us to take advantage of federal managed care flexibilities. It allows us to make payments outside of what CMS would typically approve. So a lot of our innovative payment reform models are because of this. We are able to operate our designated agency system and home health agency system because of a statewide waiver. We're allowed to have wait lists on the moderate needs population for choices for care. And we're allowed to limit amount, duration, and scope to only be provided to certain populations. So things like respite or case management services, you must meet a certain clinical threshold to receive those services. We're also able to waive the upper payment limit, which is a federal provision that says for certain categories of service, Medicaid can never pay more than Medicare can pay. This has been particularly useful in Vermont over the past couple of years, as we're paying significantly more than Medicare pays for inpatient hospitals, which is a broad category of service. So looking at any individual code, it might be higher for Medicare than Medicaid, but as an aggregate, that's what the upper payment limit looks at. And we're paying significantly higher for inpatient hospitals than Medicare pays as a program. And that's largely due to the significant amount of funding being provided to Brattleboro Retreat.
So if I could just interject really quick. This is a lot of information that we just threw at you. And the way that I helped get my head around it when I first understood it, and granted it's changed since then, but as you know, a managed care organization, a traditional managed care organization would be that operate where someone would hire you and hire them and managed care. The idea is that if they can manage the population and keep the costs down, that savings is profit. What we're doing is we are paying ourselves. AHS has hired DIVA as a managed care entity. That's the way it is. That's the logistics of how it works. But ultimately, those savings that would be achieved instead are being able to use for all of these other things that we'll be able to reinvest in the population and do these other things. And that's where the flexibility comes in. And the federal government just says, as long as you don't spend more than you would have in the absence of the waiver, you can do these other things with our permission within these guidelines and under these terms and conditions. And that's what the big negotiations are about. And that's what cash is. So that's, I don't know if that helps, but that helped me understand it when I first.
Thanks, Nolan. Move to the next slide. So this is kind of a different visualization of the top bullets on the previous slide, which just shows you our Medicaid populations, how they are eligible. So the first teal box at the top are folks that would be eligible for Medicaid with or without our waiver. Some of these are optional groups, some of them are mandatory, but most states cover these categories up to some federal poverty limit. In Vermont, we have a particularly high federal poverty limit for children under 19 and pregnant women. But these are pretty basic Medicaid categories. Then in the purple, we have our home and community-based services for certain populations. So these are choices for care, developmental disabilities, children with severe emotional disturbance, and people with traumatic brain injury. Again, these individuals would be eligible with or without our waiver. They're eligible for comprehensive health coverage. So everything that the folks above have, the full state plan benefit. And then they're also eligible for an additional array of home and community-based services. So things like supportive employment, respite, case management, to help them be out in the community and in their homes rather than in an institution. And everything that the feds have done around this purple group, this home and community-based services, is about taking away the institutional bias and figuring out how to keep people out of nursing homes, out of institutions, and in their home and in their community. And then the last two boxes or categories of boxes, the with waiver only, these are things that we are only able to pay for because of our 1115 waiver. And again, it's the V-Farm program, the marketplace subsidies, moderate needs, community rehabilitation treatment, and then our investments, our IMD payments, cost-effective alternatives, and palliative care under 21. Next slide, Nolan. So the goals of our global commitment waiver are really about advancing the state towards population-wide comprehensive coverage, implementing innovative care models across the continuum, engaging Vermonters in their own healthcare, strengthening care coordination, and accelerating payment reform. And so we're really trying to make sure that every action we're taking at the agency around the Medicaid program has those goals in mind and are working towards moving the needles on those specific objectives. Next slide. The investments, as Nolan talked about a little bit previously, these are a broad list of individual projects and programs that have been slowly accruing over time since 2005. And that link there has a list of 67 investments from 2022 that are anything from funding 211 to paying for a portion of the public health lab to providing emergency services for uninsured to mosquito repellent on a population level, like the spraying that happens. So it's a really random list of investments. These have a lot of them were generated as a way to leverage federal funding for programs that previously were general fund only. Over the next 5 years, which is this next demonstration period through 2027, we're going to be really digging into this list and seeing what measures are being collected, whether they're actually achieving the goals that they were set to achieve. In the cases where they are, we're going to be asking if they're scalable, if we can put more money in them to make a bigger impact, or if they're not doing anything or being as successful as we had hoped, can we pivot? Can we invest in a different investment or program or intervention to help meet our objectives? So this is a real focus of the next 5 years. We're currently working with our procurement team to find some really big players in the evaluation space and are looking to have a really comprehensive evaluation and partnership so that we can dig in to the investments and also to the more inherent parts of our Medicaid program to make sure that we're using data to see that we're doing what we want to do, which is improving access, improving quality, and decreasing cost.
Can I, so as you're talking through this, and Nolan gave a really good comment about how the savings are invested going forward, there seems to be somewhat of an analogy here with the prospective savings, prospective payments that we see in the ACO and the savings there that then are distributed into the provider community. So it's like an investment into the system, only in a different way. So can we think of it? I guess I shouldn't bring that up right now, but I think as you look at the ACO and look at, or the, let's not even call it, let's call it the all-payer model for value-based payments, for overall payments to providers, there theoretically makes the use of the funds efficient, and so savings accrue and then can be reinvested in some way to the providers in the system. That's kind of the thinking, I think, that's parallel with what we're doing in Medicaid.
Yeah, I think that's right. The kind of motivation in both the investments and the way that we are paying as a Medicaid program, at least we're paying one care at the ACO, is really about, can we do this differently? Can we do it better? And if you are able to change the way you deliver care, can we reinvest in things or invest more upstream so that we can divert costs from the really high acuity interventions like hospitalizations and surgery? So I think the investments are really state driven, and the idea around the all payer models that it's provider driven, but there's definitely a similar motivation there.
This is actually a great moment for me to plug an issue brief that I wrote over the summer.
Oh, good.
It's called, it's basically Medicaid, it's Global Commitment, a primer 101. And I actually just asked Alex to post it to the website. And I have a paragraph here called The Relationship with the All-Payer Model. And I'm going to read a quick sentence in there, not to quote myself, but
Well, we love that.
to quote myself, while Global Commitment and the All-Payer Model are two separate agreements authorized by CMS, they are required by CMS to be in sync. So this goes to Senator Lyon's point. According to AHS, Medicaid is the anchor payer for the APM, all-payer model, with over 80% of Medicaid beneficiaries attributed to the ACO. So we attribute lives to the ACO. Further, Medicaid and Global Commitment play a crucial role in the state's value-based payment initiatives that are central to the success of the all-payer model.
That's good. That's a great sentence.
Thank you, I wrote it.
Yeah, you know.
Actually, I wrote it, Ashley probably edited it.
Well, both of you together. I mean, this is really helpful because what it does is it begins to help us synchronize all the things that we're hearing from different places. Thank you. Okay.
So next slide.
Sure.
This is what our delivery model looks like in the state of Vermont. I don't know how interesting this particular slide is, but I think it's worth just noting the organizational structure of our waiver, which says that the Agency of Human Services is the single state Medicaid agency who contracts with a public managed care entity. In this case, it's the Department of Vermont Health Access. DVA then subcontracts through an intergovernmental agreement, an IGA, with all of these departments and agencies listed on the side. So DVA is the payer, but it is certainly not the program lead of all of the Medicaid programs. So it subcontracts mental health, it subcontracts substance use, it subcontracts special education, aging, developmental disabilities, and then children's services. So I think it's important to just note that while DVA pays for these services, a lot of the Medicaid program is administered across the agency and in the Agency of Education as well.
Yes, the Global Commitment has its tentacles, or it plays a piece in almost across almost every agency or department within AHS.
And I think this might be the last slide. I don't remember.
Okay, yeah. So this is the Untitled Chapter, which you see.
Wow,
I put this on
we've never
everything.
seen that before.
I put this on everything because we throw a lot of
Good.
numbers. But I think this is a good time to answer any questions that you may have.
Okay.
And again, I will just plug. I highly recommend that everybody takes a moment. It's 2 pages. It's a very high level Medicaid, the Global Commitment 101. So
Great, thank you.
Yeah, this is very good.
that I put on the website. Or Alex.
Yeah. No, it's great. Yes, that will be good. And we have that now. Alex, thank you for putting that out on our web page. You got it. Questions from the committee? I think I have weed questions, but I did want to emphasize.
Cannabis is down the hall, Madam Chair. I couldn't resist,
So,
sorry.
you know, I'm in the wetlands. But so I might go there a little bit. The one I think might be helpful, and that is everyone hears from time to time about a cap on global commitment, or what is the cap? What is that cap? Can you just talk a little bit about that? I'm looking at both of you, so.
I'll let Ashley go.
Yeah.
All right.
Yeah. So it's actually changed quite drastically as a result of our 2022 negotiation. So you're right. Previously, we were really concerned about a budget neutrality cap, which is that that conversation about we can never spend more than we would have spent without a waiver. And that really tied our hands in terms of thinking about new investments. And so for a really long time, there was a moratorium on investments. We weren't adding new investments. It was just like, stay the course. And we were you saw those thermometers where we were talking about how close we were to the budget neutrality cap, and we were quite close. As a result of our July waiver negotiation, we negotiated a really good waiver, and we actually were the first state to really push CMS in changing their federal policy related to budget neutrality. And what it looks like now is we can make changes to that cap based on increases in payment rates to providers. So we're essentially held harmless for any infusion of money that we put into provider rates, whereas previously, if we increase provider rates, that would get us closer to the cap. Now the cap just goes up at the same rate that the provider rate goes up. So that's really great. We also were able to take a lot of services that were paid for from investment into, we're now able to say that we're paying them through program, and created just a lot more room generally in investments. And so now our investment cap has a lot more room. And it's why, for the first time since I've worked for the Medicaid program, we're really able to think critically about those investments and think about whether there are new investments that we want to make as a state.
I can just add really quick, cap's important to pay attention to, because if we go over the cap, which as Ashley mentioned is the maximum amount we can spend over a time period for this program, if we go over that, we have to use pure state dollars. So we don't ever want to go over that cap. And so that was very restrictive. So what Ashley was just saying is we have more flexibility, because there was things we wanted to do under previous waivers, like increase reimbursement rates for providers, but we couldn't do it because we were always like, oh, we're getting too close to the cap. The other thing I want to just sort of throw out there is the first global commitment waiver was in 2005. And now we're in 2022 negotiating through 23. I think this is through 27. And it's supposed to be budget neutral. We don't know what we would have spent in the absence of the waiver, because it's been going on for almost 20 years. So it's a negotiated amount based on, calculations done by CMS and AHS. And so, the state pushing, to make sure that we have the most generous cap is really an art versus a science at this point. So kudos to, I would say it out loud, I said it once, my kudos to AHS and Ashley and the team for getting what they got in this waiver. Like, if you don't understand what we got, it's like, great. But when they got this recent one, we were all like, wow. So they deserve a pat on the back.
I do, and I do want to pat Ashley in particular on the back for the work that she's done.
Thank you.
It would be fascinating to know the process of how one gets the waiver. I'm sure it's an art form.
Well, every state, I think the last time I looked at it, 40 states have some form of waiver. And as Ashley mentioned, we used to have 2. We're the only state that has our whole Medicaid program. So for instance, other states, they might just have this small population, and we're going to do a waiver just for that population. We had one for Choices for Care, which is mostly, older folks with different needs. And a lot of states still just target a specific population. We're the only state that said, we're going to put the whole kit and caboodle into one waiver.
I would just add to what the chair and Nolan said. I was at a national conference, the Medicaid Leadership Conference, and I gave a little brief presentation on our Medicaid waiver and the rest of the states there. This was national, 26 states, I think, were there. Everybody was blown away by what we're able to do with our Medicaid program and our waiver. And some of the states who wanted to do more came up to me and, how do you do that in Vermont? And could we do this maybe with a region of our state? So I agree. Kudos to Ashley, because and whoever else was involved, the secretary and others, because it's a really great waiver that we're able to do a lot. If you look at that list of investments that we're able to reinvest, and if we could figure out a way to do this with our entire healthcare system, it would be amazing.
Well, yeah, you're right, and as we were talking about earlier, you know, moving in that direction, if we can get private insurance in synchrony with what we're doing, as well as through the value-based payment programs, we'll be light years ahead. But right now, the rest of the country, every time we talk with people, including CMS, Vermont is way ahead, and it's just it's neat. And here we have Nolan and Ashley, and they're ours. It's great. Thank you.
I think one of the reasons we get away with, or we're able to do that is because we are a small
Yeah.
state, so the federal government sees this as a very little financial risk.
Yeah, other states were like, oh, we could have a county or two doing this, you know?
Yeah, I'd also just say that like we are way ahead. We're really big thinkers, and we have been for decades in the state around healthcare. But one of the areas we're really not ahead in is our systems, our data systems, and our data collection and analysis. And so that's something that I think you're going to be hearing a lot from the agency over the next little bit. You've already heard a lot about it, but we need to get better at our analytics and evaluation and really making sure that those investments are doing the things that we want. And so Senator Hardy, if they're not, can we pivot it to a different part of the healthcare system? Like we haven't done a good enough job over the past 17 years in that space. And I think this new waiver is really going to be a time for us to dig in to the data and make sure that we're data informed.
Yeah, you're absolutely right, Ashley. Thank you for saying that.
So that is exactly the direction we're hoping that Act 167 in some ways will take us, as well as looking at quality metric analysis in a broader view, integrating data sets that haven't been fully integrated. We don't want to put them all together. That's not the goal, but to at least make the clinical data accessible for outcomes, improvement of outcomes. So yeah, we're all getting there. This is good. Senator Weeks has a question.
Just a question. So you mentioned 60 some odd investments. Can you give a couple examples, just to kind of give it some?
Tell you what, I will pull the sheet up.
Yeah, so 211, the statewide hotline, we pay for dental for people who have met their dental cap, their $1,000 dental cap, who are at extremely low income. We pay for things like the designated agency's ability to provide emergency services to uninsured, underinsured. The public health lab gets a lot of funding from Medicaid. The statistics team at the health department gets a lot of funding from Medicaid. It really runs a broad spectrum, but those are some examples.
That's helpful. Thank you.
If you go on the link, I'm struggling to get it to work. You go on the link on the, right, you go on the website.
Saw the link.
On the link. Yeah,
Here with a concept.
it's a long list and it's in like one font. But it's about, we have, $100 and something million in investments.
We can find that at the JFO site.
I will send Alex the link to post.
We'll get that on our webpage.
Yeah.
That's great. Any other questions? Senator Bullock. Senator Williams. This is good. See what clarity brings? Thank you. I have some questions, but I'm just going to throw them out there and then we can talk about them sometime as needed. I'm always interested in what Medicaid support we have for those in our correctional facilities, because that's an issue, in particular support for MAT. That's one, and I know there's some of that. The other one is there a regular don't laugh at this question. Is there a regular increase in the federal percentage? Can we ever expect something beyond a negotiated increase in federal support? Are the federal dollars, we're not on a CPI for any of this. It's all negotiated state to state.
The FMAP is not negotiated at all. So it's what Nolan was referring to in the beginning of his deck, where it's based on, kind of the health of the state economy. It is not negotiable, unfortunately. Yeah. And so we cannot move the needle at all there. On the DOC thing, just quickly, the corrections and inmates,
Sure.
there is a federal prohibition on using Medicaid dollars for inmates of an institution. And so we're largely tied from being able to use any Medicaid dollars in a correctional setting. CMS under the current administration has started to think about loosening that restriction a little bit. And so we're having conversations with CMS currently about how we might be able to pay for inmates in pre-release. So like 60 or 90 days ahead of their transition back to the community. What can we do to get them into care and make sure that care is seamless? CMS hasn't greenlit anything yet, but that's something that we hope to be able to come back to this committee within the year and say that we're able to put some money into investments in corrections.
I know that I had the room filled with all the DOC and agency folks about 4 years ago, maybe 5 years ago, where we talked about this, and now to have it move forward is, I mean, it does take time to get all of this organized. So, thank you for that work. That's really important. Yeah, and I know that Senator Sears on Justice Oversight is very sensitive to it as well, and just Judiciary Committee. It's good. Okay. Anything else? Go ahead.
I'm sorry. I just want to say, I think Nolan touched a little bit on the unwind and the fact that Medicaid's rosters are a bit inflated right now because we haven't been able to redetermine anyone over the past 3 years. That's going to be changing in May. We're going to start renewing folks. And so I want to just give you a sneak peek of testimony that we want to make sure we get in front of your committee, which is what our plan is. People for the first time in Vermont are going to, in 3 years, are going to be receiving notices saying that they have to reapply for Medicaid or that they might be losing their Medicaid coverage. And so we're definitely going to be coming back with what that plan looks like, what the communication looks like to Vermonters, so that you are able to talk to your constituents who might be reaching out nervous about notices and understand kind of what the agency is doing to make sure folks are educated.
Well, thank you for that. And so make sure that you connect with Alex so that we can get you in on an agenda in a timely way. Because I know, we all know, we're going to hear from everybody in our districts about this. So it would be good to know what the communication process will be for you and what the plan is. So thanks. It's good. Thank you. All right.
Question to Ashley. Ashley, has there been any conversations at the federal level of increasing the percent of poverty for eligibility for Medicaid? I know there is in some limited programs, goes up to a higher level of poverty, but for the overall Medicaid program, it's still quite low. And like I said earlier, the Medicaid program we have is so good, and if we could get more Vermonters eligible for it, it would be helpful. So is there any talk of that happening?
Not that I'm aware of. That would have to be a congressional law. And as we know, they're not going to be doing that in the next 2 years at least. We are able to kind of work around the fringes there, though, with our premium assistance up to 300%. So it's not as good as Medicaid coverage, but we're providing premium payments for individuals up to 300%. We go up to 317% for children under 19, which is huge. So we're able to pay for bits and pieces of services regardless of income through our investments. So I would say like all Vermonters benefit from those investments, and some of them more targeted than others, but a lot of those kind of indirectly affect everyone regardless of income. But no, short of Congress at the federal level passing a law expanding Medicaid, which feels pretty unrealistic right now, we can't really do anything.
And I know that the new waiver has the increase in income eligibility for substance use disorder treatment. And what is the timeline on that? Do you think that's going to be approved, final approval soon? Because I know it was still an asterisk in your list.
So it was approved, and we're really excited about that. So we're the only state in the country that has a federal approval to pay for substance use disorder treatment for folks above Medicaid income thresholds. This is a brand new benefit though. And so we are in this early stages. It just got approved in July. We're in the early stages of working through what are the services that we're going to cover? How are we going to enroll them in our Medicaid plan? What are we going to pay the providers? How are we going to identify the providers? So it's an enormous amount of work, not to mention our really old IT system that takes a long time to program. And so I just say all that because the 2025 date feels far out, which is what we're slating for, 1/1 of 2025. But there's just a lot involved, and our IT system makes it really difficult for us to move faster.
Not January 1st of 2025 is when you think that's going to be available. Oh, wow. I'm just thinking in context of the opioid settlement advisory committee and whether we would be able to count on any, but it sounds like no, not for 2 years.
Not for 2 years. I will say we're currently paying about $10 million a year in investments to provide a kind of less efficient version of the same benefit. So through the Division of Substance Use at the health department, they are doing a lot of work to get services to this higher income population, but it's not quite the same. It's not as streamlined or accessible as what we'll be turning on in 2025. But that's not to say it's not available at all right now, because it is.
And does it include MAT and the medication for Medicaid assisted treatment? Medical assisted treatment. MAT.
So it would, but there really shouldn't be anyone other than folks who are uninsured in Vermont, which we have very few of, who don't have MAT coverage now.
But the Medicaid coverage does include
It does.
for that,
Yeah.
the investment. Yeah, okay. All right, thanks.
Good, okay, that's good. I mean, that's helpful. And the other, if it's 2025, remember, the advisory committee is gonna come up with something, and maybe next year, maybe this year, there'll be something that goes into place through appropriation, so it might actually be very close.
Yeah.
Yeah, so. Go ahead, Senator.
Just to get us mentally prepared, do you have a sense of how many folks are gonna be redetermined? Actually, percentage wise.
Everyone will be redetermined. 100% of the people on Medicaid will be redetermined. Our kind of preliminary data, which is not sufficient, is that we think about 29,000 people will fall off. But we don't have a complete picture of the data. We only know, the limited amount of information that we know. So I think that's what Deputy Commissioner Stromolo will need to come in and really talk to you about the plan around it. But 100% of Medicaid will be removed.
Gotcha. I was looking for the 29,000, which is what percentage approximately?
Nolan's the math guy.
208,000. Well,
Okay.
no, no,
Yeah.
168 is primary. So.
15 or 16%.
Yeah, 15%. All right, thank you.
Okay, are we good?
Yeah.
I think, Alex, we can go offline. We're gonna take a little